Hello, everyone. Welcome to the webinar today. We're here today to talk about 3 years later, a look back at the impact of border closures on COVID-19. My name is Susan Rogers Van Katwijk. I am one of the authors of the research that's being presented today, and I'm also going to be moderating this session. And this webinar will present findings from recent research that was published in PLOS Global Health. 3 years ago, the world faced a really unprecedented series of partial and total border closures in a bid to slow the spread of the COVID-19 pandemic. And prior to the COVID-19 pandemic, while we occasionally saw some targeted border closures, widespread border closures like we saw in March of 2020 were almost unthinkable. And at the time, there was really little real-world data available on the evidence of border closures. And now, drawing on data from 166 countries, we have conducted new research that provides valuable insights for policymakers and for researchers. So for today's run of show, we're going to begin with a presentation from the Global Strategy Lab team that will be followed by some comments from our discussant, as well as a question and answer session. So be sure to add your questions to the Q&A box, and we will get to those later in the session, but you can add them as we go along. We also welcome everybody to add your name, introduce yourself, and where you're joining from in the chat window. So I'm just going to introduce our participants for today. Presenting the report, we have Mathieu Poirier. He's the co-director of the Global Strategy Lab and the York Research Chair in Global Health Equity, as well as an assistant professor of social epidemiology at the School of Global Health at York University. He is also the research director for the Global Strategy Lab's Global Legal Epidemiology program and the primary author of the paper that we're going to be talking about today. The second person who's going to be presenting this work is Gigi Lin, who is a data analyst with the Global Strategy Lab and has been since 2019. And Gigi plays a major role in designing, developing, and managing databases to ensure transparency, consistency, and completeness in the data, integral to all sorts of different research projects that we do at the lab. And then finally, we're going to have a discussant today, Kelley Lee, who will comment on the findings from this paper. Kelley is a professor and a Tier 1 Canada Research Chair in Global Health Governance with the Faculty of Health Sciences at Fraser University. She's also the scientific director of the Pacific Institute on Pathogens, Pandemics, and Society. And she heads the Pandemics Borders Project, which analyzes the use of travel measures during the COVID-19 pandemic and supports efforts to strengthen decision-making and their future use. So without further ado, I'm going to hand over to Mathieu and to Gigi, and we'll get started with the presentation.
All right, thank you so much, Susan, for that introduction. I'm really looking forward to going through these results and policy implications with everyone. And just like the title implies, I first want to take us back 3 years to look at what was happening at the time that these border closures were put in place. And we'll quickly transition into our actual analysis of the effectiveness of border closures in the first pandemic wave, followed by some key findings and policy implications before we go over to the discussion and question period. So let's go back 3 years and take a look at what was happening in early 2020. At the time, and we're looking back at January now, there were no border closures yet in place. There was a lot of talk. Some early countries decided to put some targeted closures at this time, mostly against China as the initial epicenter. But there's only 2 countries in January 2026 that had put targeted border closures in place, and most countries were relying on screening or some other form of travel restriction. Now, very quickly, as cases started to grow and spread to new countries, more serious discussions started to take place, and a greater number of countries started to consider putting in place, at this point, mostly targeted border closures. And so we see in February 29th that a quite large number of countries started to put in place targeted border closures, 38 at this point. Still, no countries have put in place a total border closure, but these discussions are already starting. And of course, cases continue to grow, continue to spread, and all of a sudden, what was previously mostly unthinkable started to become a real reality. Countries that were not considering putting in place any border controls suddenly were considering totally shutting down travel to all foreign nationals for non-essential travel. And as of March 31st, this is where we see the real tidal wave of border closures. 51 countries at this point have a targeted border closure in place, and 115 have completely shut travel to non-citizens for non-essential travels. And of course, this continues, and what was previously seen as a temporary stopgap measure is continuing to be put in place. And at May 1st, 2020, again, most countries in the world have a total closure in place, and 38 are still relying on a targeted closure. And as you'll see, very, very few countries are not implementing either one or the other of these measures. So that's looking back on a country by country basis, and I'm sure we can all remember what was happening in our own respective countries. But with the benefit of hindsight, we're able to actually code what every country was doing on every given day of this first pandemic wave. So on this chart, we're now transitioning to our actual research where we coded all the total and targeted closures that were put in place over this time period from January to June 2020. And you'll see in the lightest color, these are countries with no closures in place. That was the case for every country until early February. In early February, we start to see about 20% of the world's population living in a country that's put a targeted closure in place. That continues to grow through February into March. And then in mid-March, we have this massive concomitant decision by countries to put in place total restrictions. And in fact, by April, we see that about 80% of the world's population was living in a country with a total closure in place, and another 15% or so living in a country with a targeted closure in place. So over 95% of the world's population now living this new reality. On the left-hand side with the red line, you'll see spikes in transmission occurring. On the right-hand side in the orange line, you'll see incidents gradually growing across the world into April. But our question was, well, this is truly an unprecedented natural experiment. This is more or less a coordinated global intervention to control a pandemic. Did it work? And if it worked, did it work globally, within countries? Do targeted closures work? Do total closures work? These are the questions that we set out to address in this analysis. So to speak about how we did that, I will turn it over to data analyst Gigi Lin to explain our approach to analysis.
Thanks, Dr. Poirier. In terms of the real-world data, we obtained outcome measure RT, which after reviewing several sources was the best to go. We calculate this at the global and national level, and we obtain this data from Johns Hopkins University. RT is the expected number of people that a patient would infect in the real world. Using the figure on the right, in this case, an RT of 2 would mean every infected individual infects 2 more people, and so on. An RT of less than 1 means the speed of the transmission within the population would be slowing down. We also extracted country-level demographic indicators, which included economic factors, gender equity ratios, and health covariates from a variety of data sources. In terms of intervention variables, we obtained data from Oxford's COVID-19 government response tracker. This data set was very resourceful, and it documented changes in border closure controls globally. We matched targeted closures to countries that were targeted and the known caseload in those countries for each day. We verified for accuracy and completeness, and also added a few corrections of our own. All of the edits and our updates are recorded in our open access dataset, which Sophia provided in the chat below. In terms of the main approaches, our first one, interrupted time series analysis, we evaluate changes in level and slope of the 5-day lagged RT, which was our chosen time window, as this is the typical incubation period of the disease. For global intervention points, we chose the threshold of 20% of the global population having implemented either a targeted or total border closure. So for targeted, this would be February 5th, and for total closures, this would be March 19th. We also conducted meta-regression to identify factors that were associated with effective closures. For our matching technique, we use coarse and exact matching to reduce the covariate imbalance between countries with and without border closures to allow for regression analysis. When it comes to limitations with our analyses, some of our results may not be generalizable to other waves and pathogens. There are also many countries that lack the capacity or willingness to accurately report caseloads as the pandemic went on. In addition, there are numerous co-interventions, behavioral adaptations, and changes in data quality that could not allow us to estimate the true magnitude of effect. However, these effects cannot ever be separated out when evaluating border closures. Despite these limitations, we conducted over 300 robustness checks. So this included varying the lagged RT between 0 and 15 days, and we modified the time window of analyses by conducting falsification tests, conducting time-aligned analyses, censoring extreme values, and restricting pre- and post-intervention data points. Lastly, we stratified analysis for travel quarantine implementing countries. Now I will pass it back on to Dr. Poirier to guide us into our findings.
Thank you, Gigi. And I'll now start to guide us through some of the results that we obtained with those methods. And to highlight the primary result on a global level, we found that only total closures slowed global transmission. So as was explained, on February 5th, when over 20% of the world's population was living in a country with a targeted closure, this was not sufficient to slow the pandemic. In comparison, by March 19th, when most of the world was living in a country with a total closure in place, that did result in a statistically significant reduction in global transmission. And we can say that because of two separate and similar results from two different methods that I'll go through now. The first being the interrupted time series analysis. So here on the left-hand side, we have a more or less standard interrupted time series analysis where we're looking at changes in level and slope of global RT across two different intervention points. For targeted closures on February 5th, after it was put in place, and this is with a lagged RT, there was a significant increase in both the level and the slope of RT. In other words, the pandemic worsened afterwards. For total closures on March 19th, there was a significant decrease in the level and no change in the slope. And so we can say that the pandemic improved after these were put in place. Now, that's a bit messy because we're dealing with global interventions put in place at slightly different times. So instead, we tried to align each intervention by the date it was actually implemented in each country to see whether that made a difference. Now, we weren't able to do this for targeted closures because there are multiple intervention dates per country. We couldn't choose just one with varying extensiveness. So we didn't take this approach with targeted closures. However, with total closures, by aligning the dates at which these were put in place for each country, there was a significant increase in the level of RT, but a much larger decrease in the slope of RT after they're put in place. And this decrease in slope actually made up for that small increase over the span of 6 days and continued to decline afterwards. So this really backs up our results from the standard ITS. Another approach, again, was coarsened exact matching, where we're building a synthetic country that either put in place a treatment and we're comparing that against a synthetic control country. And we did this for targeted closures, compared that to countries that either never implemented a targeted closure or countries that didn't implement them at that time, and did the same for total closures. And there's several different models that we put together with different assumptions. They're all broadly consistent. Targeted closures did significantly reduce transmission within countries, but nowhere near as much as total closures did. And a really interesting result that we got out of this analysis is that we tried to account for the percent of the world's global cases that were targeted by countries and the percent of the world's population that was targeted by countries. And you'll see that the percent of global cases targeted that were known at that time made some difference in reducing transmission, but not much. And the percent of the world's population that was targeted made a much bigger difference in producing effective border closures. Going down to the country level, we were able to analyze 34 targeted border closures. And we saw a decrease in RT, an improvement in 12 countries, an increase in RT, a worsening in 10, and it stayed the same or had a mixed slope and level change in 12 countries. So about 1/3 in each bucket here. It was about as likely as there was an improvement, a worsening, or things stayed about the same. And we're able to analyze 103 total border closures. Here we saw a heavier skew towards a decrease in RT, an improvement in 41 countries, compared to a worsening in 28 and staying the same or having a mixed result in 34 countries. And the last thing I'll emphasize about the results is that we really tried to account for a variety of factors, conducted many sensitivity or robustness checks. If you think that we didn't lag our results enough, we lagged up to 15 days and have separate results for each of those assumptions available through the paper or through Borealis. We got questions about whether quarantine might be biasing our results, and separated out analysis by countries that implemented quarantine and countries that didn't implement quarantine. Again, produced very consistent results for both sets of stratification. So I encourage you to take a look at our full results, our supplementary materials online, because there's quite a lot there. So moving on from the actual results to implementations for policy. First of all, to emphasize, early and extensive closures can work. We found that both targeted and total closures did temporarily slow transmission, but total closures were more effective. And within any given country, results were really uncertain. So if you're a country putting in place a total closure, you weren't guaranteed to see a reduction in transmission afterwards. And that's even more so the case with targeted closures. We did see that late implementation of border closures, and this is for both total and targeted, reduced effectiveness, which is consistent with emerging literature supporting early action, including in a systematic review by Greppen et al. And the proportion of global population targeted was actually more important than the percent of known COVID-19 caseload targeted for targeted closures. And we think this really highlights that policymakers are making these decisions under extreme uncertainty. The data is not reliable. And if you tried to take a really tailored approach to border closures, this was less likely than taking a broad approach and targeting many countries. We also want to emphasize that we know that this crude division between total and targeted closures is not the reality of what this looked like in the real world. We have a separate paper that we're working on where we're looking at different border control strategies, looking at countries that didn't put any closure in place, countries that put in place an early total closure, countries that put in place a late total closure. And here, just so I explain what you're looking at, we're looking at from January to June, so the first pandemic wave, the percent of the world's population targeted in the blue, and the percent of the world's known caseload targeted in the red line. So because these are total closures, they're both the same. Some countries targeted just a few countries, in this case, South Korea targeting only China, and that being most of the world's caseload at the time, but rapidly declining as we go into April. Some countries chose to target many countries, even if that wasn't the majority of the known caseload at that time. And other countries chose to continually adjust the countries that were being targeted, adding countries as cases increased in different parts of the world. And we can see from that red line, although that increased the percent of the world's known caseload targeted, it really never quite reached that first percent of the world's known cases targeted in early February. So moving back to our results for this paper. Another important thing to note is that at the time, most COVID-19 border closures were likely illegal under the international health regulations. And this is because under Article 43, countries are only permitted to enact additional health measures limiting travel during pandemics if these measures are supported by science, if they're proportionate to the risks involved, and if they're respectful of human rights. So we're looking at three clauses here on this slide, an IHR international health regulation requirement and actual implementation. Countries are not allowed to implement additional health measures exclusively as a precaution. They have to be grounded in they have to ground their decision-making in scientific principles, scientific evidence, and advice from the WHO. But we know at the time that most restrictions were not supported by science, and this is mostly because the science didn't exist with real-world data. This was really an unprecedented situation, and the World Health Organization recommended against them. Under the IHR, additional health measures shall not be more restrictive of international traffic and not be more invasive or intrusive to persons than reasonably available alternatives. And we know that countries overlooked other reasonably available, less restrictive measures to protect their citizens, such as mandatory quarantine for international travelers. And finally, all health measures to be implemented should be implemented with full respect for the dignity, human rights, and fundamental freedom of persons. And we also know that many border closure decisions were made based on racism, xenophobia, rather than a legitimate decision-making process. So again, most border closures were likely illegal under the IHR. We know that less restrictive alternatives did exist. According to our findings, early and extensive border closures can cut transmission, but because border closures that are more extensive are the most effective, actually only a near complete closure of global borders did succeed in slowing COVID-19. And we're unlikely to see a similar situation where 95% of the world's population is living in a country that's put one in place within the span of about a month. And that brings us to the next point, which is that we know that countries primarily close borders because it's actually quite good politics. And it's important to recognize that and the reasons behind it. According to other research that we've done at the Global Strategy Lab, including through Stephen Hoffman's work, we know that there's at least 6 explanations that political scientists can offer for why border closures are put in place, despite what science might tell them to do. First is that it diverts blame to foreign actors and factors rather than domestic causes. It's perceived to be easier and less expensive to enact than other alternatives, even if that's not truly the case. It gives the appearance of thoroughness that all alternatives are being considered and that quite dramatic measures are being put in place. If we looked at the polling data, these measures were actually supported by a majority of domestic publics in many countries, so they were quite popular measures at the time. It allows leaders to be champions of national security, effectively moving a health issue into the national security sphere. And it can also fit with long-term practices of border orientation, effectively giving a reason to make decisions that leaders may have wanted to do anyways. So moving on to implications for border policy. First, by the time a new virus as transmissible as SARS-CoV-2 is recognized overseas, it's likely already widely spreading in unknown settings. The impact of targeted travel restrictions in preventing or minimizing transmission was likely minimal in most countries, and probably diverted resources and attention away from infection control priorities, including testing, outbreak response, and other alternatives. Border closures also place undue economic burdens on target countries. And I think this point's really important. It also discourages countries from reporting new events as required under the international health regulations. If new variants are being reported and all of a sudden targeted measures or targeted border closures are put in place against that country, that really effectively disincentivizes other countries from doing the same and transparently reporting new events. So this is our final recommendations for border policy. First, most countries are unlikely to make good use of border closures. Closures are most effective when implemented early, and yet the political will for them mostly comes after it's too late. Once there is political will, closures are primarily designed to serve political goals rather than epidemiologic needs or legal requirements. We recommend that countries generally should never enact targeted closures. They're less effective, they disincentivize other countries from reporting new outbreaks, and they're almost always illegal under the IHR. And we also recommend that we should better support the WHO to coordinate global border policies, because we can see that the usefulness of border closures really depends on what other countries are doing. And the WHO is the only organization with a mandate to make these recommendations for countries to implement closures if they're necessary. And so that is where I will wrap up and just thank the team for doing amazing work on this study. Susan Rogers and Catwick, Gigi Lin, Stephen Hoffman. This was a lot of work. And so thank you for the entire team. And I will now turn it back over to Susan.
Fantastic. Thank you so much, Mattia and Gigi, for a really great presentation of all of those findings. One of the things that I find really interesting about the results of this study is the disconnect between what border closures might be able to achieve in a pandemic situation and the political reasons that they're used, that Mathieu, that you just raised at the end. Because our study found that border closures can potentially temporarily slow COVID-19 transmission, but at quite a huge cost. And so that delay is maybe only useful if that time is going to be taken to implement other stronger measures that can do more to counter the spread of infection. But I have a sense that rather than using that time to take decisive action, border closures are actually seen in and of themselves as being decisive action. And once those political goals are achieved, there's not likely to be much action on some of that broader public health work that needs to be done and that would make it worthwhile to have put in this quite extreme measure. I want to stop now and turn to our discussant for today. I introduced her off the top, but just as a reminder that Kelley Lee is a professor at Fraser University, where she leads the Pandemics and Borders Project. And she's going to respond to our paper based on some of the work that she's been leading under that project as well. So Kelley, over to you.
Thank you so much. And thanks for inviting me to comment on this paper. It's a project that our project's been looking at this issue for the last 3+ years. So I just want to mention Karen Greppen and Catherine Worsnop as my co-PIs on that project, and many other project members who have worked on this. It's already, you can see it's a very complex issue, mixing together, science and policy in a really complex environment, very fraught. And border management through the use of travel measures has been among the most controversial policy areas during the COVID-19 pandemic. There's several reasons for this that we've already heard. We've never had to use such measures to such a widespread extent and for such a prolonged period. And because we've never done it before, there's no agreed procedures. There's limited evidence to guide decision makers, both at WHO and national governments. So this resulted in huge variation in what travel measures were used, when they were used and how they were adopted, and who they applied to as well. And while mitigation of public health threats, notably virus introduction and onward transmission, were prioritized initially, you've already spoken about the widespread and inequitable knock-on effects of these measures on the economic and social well-being of individuals, of populations, and of key parts of economies as well. So, decision makers were tasked with achieving probably an impossible balancing act. And so once again, we need to figure this out because we need to provide clearer guidance or some precedence on how to do this again if it was necessary to do so. What I think we have learned from this pandemic is that blanket recommendations for all countries not to use travel restrictions or to use them as a measure of last resort, and even describing them as illegal if adopted by countries in a precautionary way. This approach, when dealing with a pathogen like SARS-CoV-2, I think is inappropriate, and it's even unhelpful. The COVID-19 pandemic has shown that some pathogens with certain characteristics, and that would be, unknown pathogens, respiratory infections, human-to-human spread, asymptomatic transmission, those sorts of characteristics may warrant rapid precautionary use of travel restrictions. And also that there are certain contexts, perhaps where there are highly mobile populations, a globally interconnected world, large immunologically naive populations, where the use of travel restrictions may also be warranted. So, in the case of the current pandemic, the characteristics of both the pathogen and the context seem to come together, and that's not happened before as we've seen. And this may and probably will happen again. And so what would be useful is to really move from the question of, are travel measures effective? We know they can be, and they're necessary, to understanding which type of pathogens spreading in what kind of context requires what type of travel measures to be used, and when to use them, how to apply them to achieve your chosen policy goals. And I think these are the questions that are at the heart of our project. And so you're right to think, that figuring this out is very challenging indeed. And so research is still very much needed. So with that goal in mind, I wanted to make a few comments about maybe jumping off from the paper. And the first is really, we need to agree standardized terminology so that we're talking about the same things in the same way. Are we comparing like with like, or are we talking at cross purposes? And I think for the most part, we often are doing the latter. Governments applied so many different types of travel measures and describe them in different ways. Many politicians use terms in an intentional way to evoke public trust. Traditional and social media amplified certain terms that appealed to their audiences. So this subject is fraught with rhetoric that really poorly describes actual policy practices. And I'm afraid I think the term border closures is one of those terms. This paper describes 103 countries adopting total border closures. And during the early stages of the pandemic, it was politically expedient to reassure people who are understandably fearful of contagion. And there was strong public support for, pulling up the drawbridge. And so governments and then the media use the term border closures and travel bans in really, in very widely ranging ways. And in practice, really only a small handful of countries truly closed their borders. Some Pacific Island countries, so a very small number of African countries closed their land borders to everyone. In reality, most national governments restricted travel by restricted it to selected populations, such as traveling for non-essential reasons, which is something mentioned in the paper, of course. Others still did allow travel across borders, so borders were not actually closed. So in Canada, for example, we had in May 2020 alone, 680,000 international arrivals into the country. The border was not closed. Whether this was justified for economic, political, or social reasons, it's not for me to say. That's a decision by government. The point is that in almost all countries, different choices were made about who could travel and who could not travel during those different stages of the pandemic. And it soon becomes apparent from, that your paper is actually talking about not really border closures, but travel restrictions. And so, maybe that needs to be cleaned up really in terms of so we can speak the same language. So we should not use these terms in such a, kind of undefined way. They're inaccurate, they're politically loaded, and they can be quite distracting for policy decision-making. So we need to find the standardized and descriptively accurate terminology. A second and related point really is the need to understand the significant variation in what countries did and what they achieved or what they failed to achieve. And if we're going to figure out best practices and really learn lessons for future pandemic events, the real story is not how similar countries were in adopting total border closures, as you call them, but how differently countries acted. Large quantitative data sets cannot be interpreted without detailed qualitative case studies alongside them. And that's something you mentioned at the end there as coming. But I think there really needs to be some really deep diving about which countries did what and why they did them. And so in that way, we can begin to recognize that the task is managing the risks and benefits to public health arising from human mobility during these events. And these risks need to be managed, risks and benefits need to be managed, not just at borders, but prior to when people reach points of entry, and also after they cross into a new jurisdiction. So the task of risk management involves a wide array of measures that can be applied in combination, including advisories, warnings, screening, quarantine, testing, I guess, as part of screening, health certification, and so on. The term border closure suggests you slam the door. You slam the door shut, and this is one type of measure only, and it is possible. But as I mentioned, few countries actually did this, and either they could not do so or they should not do so and did not want to do so. And instead, we really can restrict certain types of travelers, but allow other types of travelers to keep moving. And that's to keep themselves safe and to keep others safe. So we need that finer detail rather than these, alongside these very large data sets. So, and the third point really is it's very difficult to isolate the effects of measures at points of entry, the actual borders, from other key variables. I know you tried to do so, and many of your analysis tried to separate those out. But how patterns of international travel changed during the pandemic was not only the result of measures, whether applied before, after, or during travel. Many people stopped traveling for reasons other than what the paper calls border controls. The early lockdown of Wuhan City and then Hubei province played a major role in reducing the export of the virus. So that had a huge effect. The fear of infection or fear of infecting others actually led to many, many people, probably the majority of people, canceling their travel plans worldwide. Airlines and cruise ships stopped providing their services, so people couldn't travel if they wanted to. And then later, the inconvenience or the cost of mandatory quarantine and testing were major deterrents and were used as deterrents to travel, nothing to do with border closures. So these all dampened travel volumes and thus rates of virus transmission that is irrespective of whatever happened at the border. And onward transmission rates were dampened. So how people complied also with the domestic measures that were then put into place, and that varied across countries, as you mentioned, masking, social distancing, lockdowns. That had a huge role to play in how onward transmission happened. So what I'm saying is, we really need to think about the fact that we cannot disentangle all of these different factors. There's multiple factors at play that shape the rates of the virus introduction and onward transmission, which takes me to the final point, and I know I need to be quick, and that is the need by decision makers for clearer guidance on how to navigate travel-related risks during future public health emergencies. And what I think this paper is right about is we do need a far more nuanced approach to the use of travel restrictions, travel measures, than the use of widespread restrictions, have to be weighed against these downstream consequences as they're described in the paper. And there's likely to be rare circumstances when actually using these measures is warranted. So how do governments in the future decide when, what, and how travel measures should be used, and also WHO as well? So already the focus has shifted from, do these measures work, to really, how do they work and when do they work? And using what's called a risk-based approach or risk analysis approaches. And that's where the focus is now. The IHR criteria to assess core capacities at points of entry are now using different language, if you might have noticed, and now requires states parties to implement strategic risk assessment in their public health responses and a risk-based approach to the use of international travel measures. The problem, of course, is, however, what does such an approach actually mean? What does it look like? What do you actually do when you do a risk assessment? And so what we're needing to find out, and this is what our project is working on, is to develop methodology and data sets to apply for future decision making. And this is a key focus, which is part of a paper that we recently published with the Migration Policy Institute, is looking at how 11 methodologies came forward during this pandemic and comparing them and seeing, what data sets they used and so on. And it's not surprising, I suppose, to say that those 11 methods or methodologies were very different. They looked at different things, they looked at different risks and so on. But there were important lessons from that. So what we're trying to do is develop a kind of decision instrument to help facilitate risk assessment or risk analysis when you're looking at travel measures, and to say, what are those key decision points? And where can we look at the pathogen characteristic? When can we look at the context? But most, and equally importantly, what's the ethical framework that informs those decisions? It's not just all about science and the nature of pathogens and the epidemiological evidence. It's really, what is your ethical framework? What are you trying to achieve? Who are you prioritizing? What's important for your society? And putting together, therefore, the science and the ethics. This is where we're going to get a better coordinated approach. So I think I'll just conclude then that, prior to the pandemic, the scale of population movements worldwide had reached record levels. We know that. And that really, despite the setbacks of the pandemic, travel will be central to how we live our lives in this globalized world. It's recovering now, but we're getting there. But it's also a very changed world. And part of that change is really understanding how to better manage risks and benefits from travel during a pandemic. There's no doubt that people traveling did spread SARS-CoV-2 initially and then repeatedly over this 3-year period, and will continue to do so. So effective use of travel measures, not simply to close or restrict borders, but to sustain travel in a safer way, and as safe as we can make it, is what we need to figure out. And so we're supporting decision makers for future events in real time to use, standardized terminology, lessons from the comparative assessment of the different practices that countries engaged in, so that we can then maybe create this decision instrument and perhaps put it under then a revised IHR that brings together both better science and better policy. Thank you.
Thank you so much, Kelley. That's fantastic. I want to move now into our question and answer session, if we can bring Mathieu and Gigi back onto the screen, and invite everybody to put their questions in the Q&A box. We'll try and get through as many of them as possible in our sort of 15 minutes remaining. And maybe I'll kick off with the question about those exceptions to travel restrictions that Kelley was just touching on. I think we know that there were exceptions to those travel restrictions. I think in March of 2020, we also, right around the time that a lot of those travel restrictions were brought in, we saw a flood of people kind of repatriating to their home countries at the same time. And so, Mathieu, I'm wondering, do we have a sense of how large those exceptions were to travel restrictions? And maybe Gigi, I wonder if there was anything that we tried to do in the data analysis to account for those differences. Over to you first, Mathieu.
Okay. Yeah, thank you. And thank you, Professor Lee, for that discussion. So many really important points in there. And actually, I think it links to this question. This big N quantitative study, we hope plays a role in informing decision-making moving forward. But of course, it's just a really small piece in a big puzzle of evidence that is needed from different disciplines, methodologies, small N, qualitative, policy study. And we hope this works into that matrix, but we definitely need much more study into these complex issues to figure out what's going on. With regard to how actually extensive or total border closures were, this is not what our study looked at. So we can't address that question, but it is so important to study either through our group or others, whoever's willing to look at this. Something that we did look at that was related is that we were surprised that some targeted measures, targeted travel restrictions were, according to the data at the time, really poorly targeted. They allowed travel by about 5% of the world's population, 10% of the world's population, but at that time, 30 to 40% of the world's known caseload. And so we were kind of perplexed. Oh, why would countries do this? And of course, a lot of it comes down to policies and politics, free movement within the EU, and different considerations about, well, how much travel can we restrict? What are we bound to do for other countries under international law? So these are not easy decisions to make for any policymaker, and we certainly recognize that. And just the interesting results that I can bring to that question is that actually those countries that poorly targeted, that targeted many countries, but not some really high-risk countries, that was actually as effective or possibly more effective than countries that really try to take a purely data-driven approach and say, I know that hotspot, I'm going to target it, and I'm going to leave travel open to others. And that's, again, probably because we had poor data, poor information at that time, and that's not likely to change in the future. I think we need to accept the reality that when a pandemic threat like this emerges, we're going to always have poor data and information by which to make these really difficult decisions. So I guess I'll pass it over to Gigi if you have anything to add to that.
During the course of I just want to add in terms of the data side, when we were hand coding the matrix of the travel restriction data set, we did note from Oxford's documentation, but also from our own scouring of the web, whether there were certain decisions made on the part of countries where they did include that non-essential travel. So that was part of, back when I talked about matching the targeted countries to the country day and the caseload, part of our analysis, how we feed it into adjusting some of the values that went into our analysis. But other than that, we weren't able to fully capture the extent to which targeted travel had some kind of adjustments on a country by country basis, based on this essential travel group of people.
Thank you both. We have another question in the chat, and maybe I'll direct it to Kelley. So one of the overarching aims of imposing these kinds of border restrictions was to prevent sort of health system collapse in different countries because there wasn't capacity at the time to deal with those massive surges of patients. And I guess I'm wondering, do you have a sense of how governments navigate those decisions about whether these measures are justified in the face of those kinds of unknowns?
Yeah, this is a really important question. And I think it gets back to my point about context. So, you look at the pathogen characteristic, but you also look at the context where this pathogen is going to land. So you have a country that has a healthcare system that will really be, decimated, or at least not be able to respond to the perceived threat that's emerging. Then you can, justify the use of stricter measures at borders until you can manage the inflow of new introductions. There might be, waiting until vaccines are available, for example. And so there's not just one thing. There are different decision points, and different countries will make different decisions. And I guess the move is towards getting decision makers to make those decisions in a transparent and accountable way, but also in an evidence-informed way, and so that they can decide for themselves what's best for their jurisdiction. We may not, a coordinated use of travel measures doesn't mean that every country will do the same thing, but they'll be doing a similar kind of decision-making process, which will lead to less chaos. And I think that's where we're heading towards, not the same things for every country, because it wouldn't be appropriate. I think that's the added complexity of this issue area.
That's a very important complexity and a great lead in to my next question for Mathieu, because I'm curious about the differences between what high income countries were doing and what low and middle income countries were doing, and if there were differences between the successes or the results that they saw of implementing these kinds of border measures.
Yeah, let me address that in two parts. First, just based on our results, we did actually stratify analysis between high income countries, low and middle income countries to see if there's any systematic difference in our results, and there wasn't. So that analysis is in the supplementary materials. There was no systematic, if targeted total closures are more effective in either sets of countries. But I think it's important to note that decision-making process might be different depending on context. If buying a little bit of time, even if it's uncertain and not guaranteed to work, to implement public health measures to prepare a health system that might be heavily burdened or lower resourced for what's about to come, if you can use a border closure, a travel restriction to buy that time, and you need that time, then absolutely it is something that should feed into decision-making. And I think it's also very important to recognize that based on this experience, it is possible that these measures, whether targeted or total, although total is more certain, will buy time. And we have to recognize that this is also part of that emerging evidence. And this is something that the WHO was not able to draw on before the pandemic to produce recommendations. So I think it is, first of all, important to recognize these measures can help to buy time. It's not certain. Total closures are probably more certain. And even though they're not more or less effective in higher or lower income settings, that decision-making process might be different, and it might be more worth taking that risk if you need that additional time to prepare. I don't know, Susan, do you have anything to add to that one, or?
No, I don't think I have anything to add specifically, but I do have a follow-on question from that, because I think you've touched on a lot of evidence that we have now that didn't exist in March of 2020. And alongside that, there are a lot of processes that are ongoing at the moment to revise the international health regulations, to develop a new pandemic instrument. And so I'm wondering, and I guess this question is to the whole panel, but maybe Mathieu, you can respond first, and then we'll go on from there. The new evidence that's been generated in this paper and papers that Kelley's group has put out, what do you think that means for these new processes to revise the IHR or for the pandemic instrument that's going to be forthcoming in the next year or so?
Well, one takeaway is for me that there's no unopening Pandora's box. This is now the new reality. Countries will be immediately considering travel restrictions, targeted total closures as a part of a policy package for any new emerging pandemic threat. And that's just the reality. So I think those revisions have to take that into account, and we have to face that new reality and produce recommendations for what should happen in these decision-making processes. And even though this is outside of the bounds of what we analyzed, when the first global Omicron wave started to take hold, countries punished the country that openly reported that this new variant of concern existed, was transmissible. And again, that will have the effect of having countries think twice about openly reporting these events in the future. So we really have to think deeply about incentivizing countries to do the right thing, to report, and how travel restrictions and border closures fit into that incentive structure.
Thanks, Mathieu. Kelley, any thoughts from your side?
Yeah, we've been giving this a lot of thought. That was the starting point of our first project, was to look at IHR compliance. And, I've said this to Mathieu and to others before, that I don't agree that these were illegal, these initial adoption of travel measures. If you look at Article 43, it's actually quite broadly worded. Yes, there has to be a following of scientific principles, but or evidence, but when it doesn't exist, what do countries do? I think WHO would admit now that its initial recommendations were not what they would do again, that actually it was too crude. And what they want to do now is, again, as I say, gone a bit funny on the screen there. That they want to move towards more, as you say in the paper, a more nuanced approach. So I think the way forward really is to, I have looked at some of the revisions proposed. They're not very maybe groundbreaking. They need to be more fundamental on how we actually operationalize what they mean by a risk-based analysis. And there may well be an appendix, for example, that can be updated as technical guidelines on how to do that. I think that's where we need to put our focus. We are in a different world, and we're now in a point where, travel measures are recognized as needed, the full range from advisories to complete closures. And there's a lot in between. And so that full menu really needs to be on the table, and not just what they call restrictions, travel and trade restrictions, as the phrasing is, which is vague, right? And sometimes you want to enable travel. Sometimes you want to restrict it. So that needs all to be updated in a highly mobile world. So the IHR, I think, would benefit from some revision in that sense.
Thank you both. I think that unfortunately brings us to the end of our time for this session. So I just want to thank all of our panelists, our presenters, and Kelley as our discussant for taking the time and coming to chat about this today. I believe that we will be sharing the link to this study in the chat so that everybody who's here can have access to that, as well as following up with a recording of this webinar that'll be sent out to folks who might have missed it, so you can share widely. And I think that's it. So a big thanks to everybody for participating. A big thanks to everybody for joining today.
Thank you.